in your life.
All right, good morning. This is Senate Health and Welfare. It is January 23rd. And this morning, we're going to look at electronic medical records. So I've invited some folks in who are experts in this area and can educate us a little bit. And then we'll be thinking about, we'll have a bill in here that tries to bring together our medical records for improved patient access. We'll also be meeting with some of the folks from the various AHS departments. So we'll start with an introduction of the committee because there are people here who haven't met us yet. We'll start here.
I'm Senator Larry Hart from Orange County. I live in town of Thompson. Can't get there from here.
I'm Sam Douglas from Orleans County.
Jenny Lyons, Chittenden Southeast.
Martine LaRocque, Chittenden Central. And Cummings, Washington District, right here.
All right, good. So we're going to begin with some information from Beth Anderson of Vital, and she can introduce herself and her organization. And I think she's on.
She's right here. I'm here. She's right here.
Oh, you're here. I didn't see you. Sorry, Beth.
And actually, I'm
The
here
chair's yours.
just to be trouble. I'm here with Will Dempsey from AHS, and we'd like to do it together.
Why don't you bring your both another chair up? That'd be great. And Lucy, do you mind touching the OK up on the screen? Thanks.
I'd like to squeeze in here.
Oh,
Yeah. Thank you. Sorry, just trying to not hurt anyone.
Good morning.
Good morning.
So for the record, why don't you introduce yourselves and then it's all yours.
I'm Beth Anderson. I'm the CEO at Vital, the Health Information Exchange for Vermont.
For the record, I'm Will Dempsey. I am the Health Data Officer for the Agency of Human Services. So I think, Chair Lyons, it might make most sense if I go first and then Beth follows.
That's fine. That's your
Preliminary 101 stuff. Perfect. Not used them very often. Let's do the whole death. Yeah. There we go. Perfect. Oh.
Thank you. Great. Perfect.
Good morning, everyone. Chair Lyons, okay if I dive right in?
Yes, please go right ahead. And the question will be, do you want questions as you're going along or do you want us to hold them till the end?
Questions going along would be great.
Okay, good.
So a brief agenda. I'm going to run through what the concept of health information technology is. We're going to talk about the benefits of that concept, a little bit about something that Vermont has. It's called the Unified Health Data Space. And then I'm going to talk a little bit about the Health Information Exchange Steering Committee that we have here in Vermont. And once I'm done with my slides, I'll hand it over to Beth. And she has kind of complimentary slides to run through about what Vital is and what Vital does. And we'll go from there. So some foundational concepts on what health information technology is, commonly referred to as HIT. I'm going to try to not use any acronyms. So if you catch me using an acronym, please feel free to interrupt me and tell me. What is health information technology? Technology systems designed to collect, store, and manage patient health data. So it's in the healthcare space. And why is it important? Is that it improves patient care, it streamlines provider workflows, and supports better decision making by patients and providers. And then the ultimate goal of HIT as a concept is to deliver better care, improve the health of the population, and reduce costs. A few good examples of HIT, health information technology, are electronic medical records, commonly referred to as EMRs, electronic health records, commonly called EHRs, and health information exchange, HIEs. And I'm going to pick apart what each of those is, so that way we can make sure that you all know what I'm talking about. So electronic medical records versus electronic health records. What's the difference between the two? So an electronic medical record is basically a replacement of paper charts. I remember going into my primary care doctor when I was young, and they literally would pull out a paper file, open it up, enter information into it, and then somewhere along the line, they switched over to tablets. That was an electronic medical record. It's a one-to-one replacement. It's usually specific to patients within one facility. So think a doctor's office, or even one provider, if the provider is a solo practitioner. And it does track data over time for patients. So you can see like, oh, this person received an immunization, they received their tetanus shot. We all get those every 10 years. And then, oh, well, they're missing a flu shot for this year. We need to give them a flu shot. Electronic health records do what EMRs do around tracking patient data, but they do more. And that allows them to reach between facilities and between providers. So they're built to share information, including patient history, so that way your entire record is all transferable, as well as lab results, prescriptions, things like that. So that way your whole medical record is there. And they're built to share and focus on the whole person care and coordination. So coordinating the care of that person between specific providers. So what is health information exchange? It is a platform that enables patient sharing information across providers between different electronic health records. So provider A in Winooski has one electronic health record. They're able to connect and share data through a health information exchange with provider B, who could be in Montpelier. And they don't have to fax anything. They don't have to have any sort of direct connection between them. They can share the information through the through the health information exchange rather. And another important part of this is the provider portal, which allows providers to access the information that's in the HIE for their patients. So they could go in and see, my provider can go and see my record and see all of the records that have been contributed to the HIE from providers. Yes.
Thank you, Chair Lyons. Where would my chart fit into one of these? Great
question. So my chart is under Epic, which is an electronic health record company. And it's an example of a patient portal, which is a concept that allows patients to have direct access to their own medical records that are in the electronic health record.
So it's considered an EHR? Is it considered an EHIE?
So, sorry, John.
No, go ahead.
So my chart is an example of a patient portal that's connected
It's just
to an
a patient
electronic
portal. Okay.
health record.
Okay, gotcha. Thank you.
Okay. What is the purpose of HIE? It allows seamless data flow and access across different providers. So if you go into the ER, they can look up your patient record, versus if you're going into your primary care, they can do that through the health information exchange. It also ensures that if you get a lab, you get a test at one provider, other providers that you go and see, say you go to a specialist and you get a lab test for something, and you go back to your primary care could go through the provider portal and see that information. And all the hospitals in Vermont are connected up to our health information exchange here in Vermont. And it also allows a lot of data sharing for public health purposes with the Department of Health. So why does it matter? I talked about redundant tests. You don't have to get the same test twice. If you got a test, you go into the ER a couple days later, but the result is in. They can look at that result rather than having to retest you. Improves patient care coordination between providers because they have the information between them, and then improves population health reporting because that data is able to be looked at the population level. So how are Vermonters is a great question. An example of an HIE that Beth is going to get deeper into is the Vermont Health Information Exchange, commonly called the VHI, which Vital is the legislatively designated operator of. So I'm not going to get too deep into Vital because I don't want to steal Beth's thunder. So an analogy that we use pretty often is the post office analogy because it gives a tangible concept to look at. So on the left side of the screen, you'll see hospitals, but it doesn't just have to be hospitals. It could be any type of medical provider that's contributing data. They're submitting their letters, which are clinical data, and it flows through what we call interfaces. Those are the mail trucks that you see up there into the post office, which is the Vermont Health Information Exchange. And then the data is able to flow out to providers, to public health, and to payers on the right-hand side, payers, health insurance companies. So there's a lot on this slide. I don't want to get too deep into it because I want to keep it at a kind of high level for today. But there are national standards around HIE and how the data is transmitted, and how it's formatted, and how it's used. There's security and privacy considerations at all levels. And we also have federal statutes that we have to operate within as well, including HIPAA.
So I'm looking at the little HIE boxes all across, and I see a whole lot of acronyms there. Just one time, just say what they are, if you don't mind. It's because it'll help. Gradually, we'll all get it.
Yes, of course.
Yeah.
Thank you, Madam
Good.
Chair. So in the HIE infrastructure blocks, I see MPI, that is Master Person Index or Master Patient Index. It's kind of the older term. It's evolved now to more Master Person Index. Over in the National Standards for Interoperability, you have USCDI, which is the United States Core Data for Interoperability. That one is defined at least. We have CMS, Centers for Medicare and Medicaid Services, federal agency. CDC, Center for Disease Control and Prevention. ONC, Office of the National Coordinator for Health Information Technology. SAMHSA.
Substance and Mental Health Services Administration.
Thank
You
you.
better say it louder.
Substance and Mental Health Services Administration is the part of federal HHS that manages those services.
Thank you, Brendan.
Sorry.
So
For the record, you should say.
Oh, for the record, my name is Brendan Krause and I'm the Director of Health Reform at the
Thank
Agency
you.
of Human Services.
thank you, Madam Chair. FHIR is Fast Healthcare Interoperability Resources. And then off to the right, you have HIPAA, which is the Health Information Portability
And Accountability.
Accountability Act. Sorry, I heard something and I got started. So that's the post office analogy.
I think there are two P's in that one, right?
No,
HIP,
yeah.
one H.
Two A's.
2 A's.
Wow.
I always,
Patient portability.
yeah, I want to put 2 P's in it as well, Madam.
It was a long time ago.
We gotta fix this.
So what are the benefits of health information exchange? The current benefits are that there's a comprehensive electronic patient information in the health information exchange from providers who contribute and for patients who are in the system. And it's available when and where needed. That allows medical professionals to have complete and current information to make clinical decisions with their patients. And then test results and imaging results are always available, which eliminates repeated tests, which are expensive and time consuming. And then, of course, real-time aggregation to detect patterns in the data. Future plans for our HIE include quality and payment information being derived from one record of care. And then an important one that I want to also emphasize, patients having access to their own records through the health information exchange rather than just through a patient portal at their provider level. So I want to give just a quick overview of hospitals that are connected to Vermont's Health Information Exchange. This list includes hospitals in Vermont and New Hampshire. It's the full list. And it is by which vendor they use for their electronic health record. There's many, many vendors that provide services around the country, and they all seem to always be vying each other. or rebranding. So we have 4 that use Epic, and I want to also flag that 3 of those are UVM Health Network hospitals. We have 5 that use Oracle, which was previously Cerner until 6 months ago or so. TrueBridge, which was formerly CPSI, there's 3 of them, and Meditech, which is another vendor which has 4. So it's split out amongst these 4 pretty major players in the electronic health record space.
Can you just talk a little bit about what they do? Again, just to reinforce what this means for electronic health record vendor. What exactly, what's here? What's Epic?
Yep.
What does Epic include? What does Oracle include?
Of course.
Okay. Yes, ma'am.
Can they talk to each other? Because when we started, and it wasn't that many years ago, my husband's primary care provider was in the office building at UVM. He had an allergic reaction to a medication, went into the emergency room, same hospital, and they couldn't find out what medications he was on. Now, everybody there knows all of that. But at one point, I think my last trip through here, UVM had a separate vendor and CVH, and they couldn't talk to each other. Can we now all, because I was thinking.
That's where we're going. This is a
Okay.
great question.
Because I asked my doctor, how do I get on to Vital? Because we had opt-in and opt-out. And
That
she had no
access.
idea. No one had ever asked me if I wanted my records on there. And the doctor didn't know. She told me to ask the receptionist. So
You mentioned,
it sounds like we have progressed so that everybody is talking to everybody. And it just happens. I don't have to opt in or opt out, which to me is good.
you do sign something, but I'll let you answer. First, the question is, what do each of these do? And then that may get to some of Senator Cummings' questions.
Of course, not here.
Okay.
So by vendor company, these are separate companies. Some are, I believe Epic is privately owned, and some of the others are public or shareholder owned. Many of them are very large companies. Oracle is a multi-billion-dollar company, as is Epic. TrueBridge and Meditech are a little bit smaller than that. They're not on the multi-billion-dollar end of things. So each of them offers services to providers. So they're able to use that system to manage the care of their patients and record the information. What are the blood pressure readings? What are the medications prescribed? And then many of them, they have connected services, like you can connect them into your laboratory. So that way your laboratory results are seamlessly transitioned into the patient record at the EHR, electronic health record level. And that allows within a facility great coordination. So they're able to address things like the example within a facility where it comes to between facilities. That's where Madam Chair talked a little bit about interoperability. Beth has lots of information on that, so I don't want to steal too much of Beth's thunder.
Okay, but we will get the answer, right? That's
I
good.
will do my best.
All right.
But I'll touch on it.
Well, I'll be patient.
Thank you. I appreciate that. Interoperability is a concept that enables these electronic health records to communicate with each other and basically speak the same language. And they speak that language through generally a health information exchange like Vital. So by having these standards, Vital is able to ingest that data from these electronic health records, put it into their database, and then make it available to providers. And anything that I missed from your perspective,
If you don't
please?
mind if I add, no, you did a great job. I think the thing I would also say about the implementations of the EHRs within the different facilities is they may have, as you said, implemented different components or differently, but they also can be different versions. So even Oracle is a good example. They have different versions of their software. So they might not, even if one uses Oracle or two use Oracle, they may be very different implementations. And so just have, it's not the same as having like Microsoft Word and it works the same everywhere. it can be very different how it's used at each organization. So it can challenge the sharing of the data between everyone that's on the same platform.
Think about it. Sorry.
Hi,
For the record,
for the record, my name is Eli Hoggett. And I would just like to add that, the Office of the National Coordinator, also,
before you go any further, state your name clearly again and then who you represent.
I'm Eli Hoggett. I'm the Health Information Exchange Unit Legislative Liaison, and I work for the Agency of Human Services.
Thank you.
During a period called Meaningful Use, which was in the early aughts, the Office of the National Coordinator set up different standards that all certified systems must be able to accomplish as a certified electronic health record system. And so all of these vendors must be able to meet about a dozen basic core usages for any of their customers.
Thank you.
Did I answer your question, Madam Chair?
Well, it answers mine.
Okay.
And we're being patient with your coming. Senator Douglas has a question.
I've heard some issues with Cerner, some controversy with Cerner versus around like lawsuits and some stuff like that. Is there anything you're aware of?
So Cerner sold their
Yeah.
EHR functionality, just that division. They have other divisions to Oracle. I'm not familiar with specific lawsuits in other states, but I'm willing to bet most of these companies are probably being sued at any given time.
Sure.
Yes, I know that the chair of the Agreement Care Board has been involved in some of those, so he's very sensitive to that.
You may be hearing about Cerner in the news too, because they have a very big Oracle now, very big implementation with the Veterans Association, and the joint HIE for the Department of Defense and Veterans Association that has gotten a lot of press and has some challenges. So that could be that there's some very big information about their EHR in particular.
All set, Chair. So what I want to talk about the goals of Health Information Exchange in Vermont. These are the goals that are in our Health Information Exchange strategic plan that we draft every year and by statute submit to the Green Mountain Care Board for review and approval. So the goals that we maintain are create one health record for every person, have better health outcomes, improve healthcare operations, and use data to enable investment and policy decisions. So those are our 4 guiding lights in what we do in Health Information Exchange in Vermont. And one of the concepts within that is a concept called the Unified Health Data Space, UHDS. This has been around for several years at this point, which is a concept to build collaboration to streamline data, especially healthcare data within Vermont. And that the costs would be shared out with the federal government picking up a significant part of that tab, and to also do what's called reuse, which avoids duplicative efforts. So the same infrastructure used for multiple things, so that way we only have to spend the money once, 3 or 4 times. And it's a key part of our reform efforts within the healthcare space, and includes a broad spectrum of providers. I have a few types of providers and stakeholders listed here. We have providers themselves, which are point of care. We have accountable care organizations. We have payers, health insurance. We have the Green Mountain Care Board, healthcare reform team, Blueprint for Health, and then patients, and ensuring that they have all of access to all of their records as well to make empowered decisions. And then finally, population health, which is related to addressing health equity as well as public health. And a few examples of the types of data that will be in the unified health data space are clinical data, that is data collected by providers at the point of care, mental health and substance use disorder data, social drivers of health data, as well as public health data. So things like registry integration, birth and death record integration, things like that.
Senator, you have a question.
Just curious, one of your goals is better health outcomes. Is there any data that point to the fact that there are better health outcomes because of these services? Or is it still too early to?
Still too early, but I can look and see what we have and get back to you.
Thank you.
Yeah. So I want to talk a little bit about our steering committee. This is the Health Information Exchange Steering Committee. This is a group of folks that are in law and meet regularly to help guide the direction of the health information exchange in Vermont. I am the chair of this steering committee, and we have representatives from 18 different organizations, including many that you all are probably very familiar with. I want to highlight that we have a really strong relationship with the Department of Health and integrating their data, which is pretty rare in the health information exchange world. And then we also have a lot of collaborative work with each of these organizations, including down at the bottom, you'll see Beth listed for Vital, as well as the Deputy Secretary for the Agency of Digital Services, Stephen Andrews from the Green Mountain Care Board, and then we have a privacy expert who unfortunately recently left, so we are working on replacing them.
That's an important place.
It is an important place. We're working diligently.
Okay.
Okay.
So this is the steering committee. The formal title of the steering committee is Health Information Exchange Steering Committee.
Yep, and I have some definitions and things on the
Okay,
next
good.
slide.
Yep.
Including the citation where they are in law, which is 18 VSA 9351, which outlines their responsibilities as a steering committee. And I included kind of summaries of those. It's not verbatim from the law, but they're involved in our annual health information exchange plan, which, as I mentioned before, goes to the Green Mountain Care Board right now, and they review and approve. And that's done on the calendar year. So I'm required to submit that by November 1st. And that sets our scope for the coming calendar year, as well as our priorities in that work. And then they're also charged with consulting on the administration of the plan throughout the year. So I meet with them regularly, give them updates on what's going on, what's happening, and ensuring that they're fully aware of, at all levels, what's going on in the health information exchange. And our focus with that team is building a multidisciplinary, diverse team of experts to ensure that we are maintaining compliance, building engagement, and ensuring representation. And one thing that I forgot to highlight on the previous slide is that we do have a person advocate who represents like lay people on the steering committee itself. And we also include the Office of the Healthcare Advocate.
I think I'm sorry to butt in,
Please.
but I think a good point to point out is that committee has changed over time as needs have been identified or new partners or stakeholders have been included. So that's been really helpful. I think the patient advocate was an important part, and also having research representative. I think it's a good thing to know that is an evolving team as we identify needs.
Thank you, Beth. Okay, I want to touch on our stakeholder engagement and governance process. And this is my last slide. So after this, we can start handing things over to Beth. So we have our steering committee, which I just talked about. And there is a bullet on here about routinely adding new roles as we identify as we identify new data sources and new partners, we add them to that organization. And then we also have a data governance council. These are public meetings that are posted on the board or Department of Libraries website, where we discuss the data that's in the HIE, and they have the authority to make decisions. And we talk extensively about consent and privacy and things like that in the Data Governance Council. And there's links to our website and where that information is as well. We have our annual strategic plan, and I included a link to our current plan as well as our statute around that plan. And then the Green Mountain Care Board's requirements around reviewing that plan. And then finally, just a link to our website and where we put our information so that way we can be as transparent as possible with the public.
Our capacity is 16. I think we're at 17 now.
Oh, okay.
Thank you.
Thank you, Sandra. Okay, so now we are fully informed. It will take time for it to all settle in, but we appreciate the amount of work you put into those slides. Very extremely helpful. So we'll take some time to look at it, and this isn't the last time I think that you'll be in here. We will be trying to deal with this a little bit to do what we can do to help link records across different improve access, let's put it that way. I don't know how much we can do or who will be responsible for doing it. I'm not sure all the decisions will be made around this table. The other places, perhaps the steering committee will see how it goes.
So I get started. Thank you. So as Will mentioned, I will talk a little bit more specifically, a lot more specifically about the work we do here in Vermont. I will also try to avoid acronyms, but I will warn you, the one I will continue to use is VHI, and that is the Vermont Health Information Exchange, just because it's a big mouthful for you to hear over and over again. So we are, Vital is a nonprofit organization. We have an independent board of directors who represent a lot of the healthcare community across the state. And we are, as Will mentioned, designated in statute to operate the VHI, the Vermont Health Information Exchange, which is a network that shares data across providers and other stakeholders in the state. So really the point of having an HIE is to encourage interoperability across providers. So we offer the ability to collect the health information from the disparate systems and organizations and sources that create data on patients or capture data on patients. We do a lot of work to clean it up, which I will talk about a little bit, and make it available for a lot of different purposes. So what I'd like to just talk about a little bit is what we do with the data to make it usable across organizations. And I promise I will not get into a deep technical discussion. If you want me to, please ask questions. But when these systems, these EHRs or other systems are implemented at an organization, they can be implemented very differently, as I mentioned. And so that can be very vast differences. It can be minimal differences. It can be simple things like some organizations will capture male, female as M and F, and others might capture it as 1 and 2. And it's simple things like that. It can be much bigger things, how they capture, how they, what codes they use for lab tests or results. And so what we do is the HIE is work with the organizations when we build these interfaces to collect their data to try to standardize and normalize the data so it looks more similar across organizations. So if I have a lab test from, I'm just going to use examples from UCM and a lab test from Dartmouth, you'll know that it was the same test or a different test and how to compare the results. And we try to do this work with the organizations. We also do a lot of work to do what's called patient matching, as Will mentioned. We have a patient index, which allows us to take information from different individuals at different organizations and have try to gauge confidence of whether it's the same individual. So if somebody had a test 2 years ago under the name of John Smith in Southern Vermont with an address in Southern Vermont, but now moved to Northern Vermont and 2 years later had another result come in with John Smith at a new address. We have reference data that we can use that actually helps us match that up. And the goal of that is to create that single patient record. So we have a really longitudinal record on each individual. And we use a national service, very leading edge service to help us inform that work. So we have good information to try to put those records together. And when we can compare against them for data sets that we tend to use on individual patients, and we can traditionally, when new records come in, match them to an existing patient record about 96% of the time. So we really have good, solid information on the individual that's consolidated. Real benefit of having the HIE is really encouraging interoperability, right? And that, but another benefit, like interoperability can mean a lot of things, but really having an HIE at the center of this also really it lessens a lot of burden for providers and organizations creating health data, because they deliver the data to Vital, to the VHI, and we make it available to other organizations on their behalf. And that can really run a large range of types of organizations and stakeholders that we work with. So it's people providing point of care for patients, emergency medical services, a doctor in a doctor's office, health information management teams, care coordinators, that's in across community organizations, as well as within healthcare organizations and payers. We inform quality improvement, public health activities and population health activities. I think an interesting thing to know about our HIE here in the state that varies across states and across HIEs is that we do collect the data. So some HIEs will really work about just moving data, taking it from one place and delivering it somewhere else. But we capture the data, which allows us to really inform a lot of the work that happens here in the state. And particularly when we talk about some of the population health and quality improvement, we made data available to the Blueprint program, which uses historical data, not just currently what's happening. So we have that the longitudinal record is also the history that allows us to do things that might not be able, won't happen just where you're doing query based and kind of just on time information sharing. Before I get further into some of the services that we offer, how the data is made available, I think it's helpful to give some context.
So I'm going to go back to the last slide and go back to Senator Cummings' question about the person who was asked your question about the individual.
Well, first, I think I've gotten the answer is I don't need to do anything. That my record, if I have a test, every doctor that turns on their computer in the system knows the result of the test. And before CDH was affiliated with UVM, that wasn't necessarily so. And if I had, it used to be, I wanted to sign into Vital because if I were in an automobile accident in Rutland, they needed to know if I were allergic to a medication or whatever. It sounds like now Rutland can access my medical record. If I get very far from the border in New Hampshire, it gets iffier. Definitely California, it's iffy. But we're in better shape than we were. I remember Vital was Mike Smith's first, I think, business salvation or
Exactly.
he's resurrected several places, but I remember finance had to do something. Yeah, to help keep Vital afloat. It was a rocky start,
It was a rocky start.
but it sounds like it's in much better position and people are better off for it. I don't necessarily have to carry around a card with a list of all my medications on it, even though they ask me every time I go in. No, it's everything you've got there and I can pronounce none of it. But I think I've gotten my.
Good. Yeah, no, that helps.
It's improved a lot since.
It has, right? That it really has. It's amazing. Yeah.
There's more for us to do though, right?
Yeah, that's more to do. So we've gotten to another step. We've taken a
We have
step
an
out.
automobile accident in Concord.
Yeah.
New Hampshire, I don't know that they would know, and I know I don't know every medication my husband's on.
Senator Gulick also has a question.
Just wondering how many folks opt out, if, assuming you can opt out, and if that skews any of the public health data that you end up gathering.
Yeah, we have about 1.1% of Vermonters opt out of sharing their data. I'll touch on that a little bit later, how we educate them about knowing what their options are and how their data is being shared. Public health does have their particularly coming out of the pandemic, they have some allowances to see data for certain purposes in public health of all patients. It can be used, the individuals who decide to not share their data can be accessed in some public health cases for specific purposes. And also, sometimes you can do what's called break glass. So if they show up in an emergency room and there's no way for anyone to know anything about them, a treating physician can decide that this is an emergency and it's a life or death situation. We need to see if they're allergic to something or if they have a condition, and they can see that data. Okay, go on. Great.
That was a good place to start.
It's perfect. Yeah. So again, I just a little bit of context of who participates and what data we have before I start talking about some of the services. So hopefully it provides a little context. The column on the left is who gives us data or sends data to us. On the right is who uses our data, and the numbers are slightly different. As Will mentioned, we have all the Vermont hospitals connected and sharing data. Dartmouth also shares data on Vermonters. We do also provide data to another New Hampshire hospital, Border Hospital. All of the FQHCs or the federally qualified health centers are connected, sharing data. All but one access our data, which is great. We have a number of independent specialty and primary care practices. Something I should be careful to specify is when we say hospitals, the hospitals themselves are connected, but it usually means their community practices, their specialty care practices as well, and not just the main hospital building and those services. We are connected to some home health agencies and nursing home long-term care facilities. We do get data from pharmacy chains and independent pharmacies. That number of 11 is not locations, it's an actual chain. So it would include all the community organizations. Largely what we get from them is immunization data. We're connected to a number of labs. It's the hospitals and the state lab. We work with a couple of the departments of the state to get and share data. We provide data to the designated mental health agencies and social services agencies, the Part 2 providers across the state. Emergency medical service is a really great story that's really grown since over the pandemic. They don't have a lot of data when they're out in the field providing care to patients, and our team has worked closely with them to help them get access to some of the data so they have information, and they're using information. A little bit of a tangent, I'm sorry, but it's a great story. They're using the information not only to inform patient care, so they're more prepared, but they're also using it for some of their after events, quality improvement, so they can evaluate. Now they know what happened to a patient. Before they didn't necessarily know the ultimate, so they can see, was our care appropriate? Can we do things differently? What can we learn? And then finally, we do work with some commercial payer who uses the data for some of their work.
Okay. So by contributing data, does that mean like they're the designated mental health agencies or the commercial payer or the one hospital of the 16 we have that isn't there? That means they're not updating records, they're not making changes if there's errors or anything like that.
Yeah, there's different reasons for that. Commercial payers do submit data to the Green Mountain Care Board. We haven't requested it in the HIE to date, so we don't take the claims data in. Emergency medical services don't have systems that they capture the data in to share the data with us. Designated agencies, there are rules specific to substance use disorder data, federal rules about how that data can and can't be shared that are being changed right now. But there are some pretty severe restrictions on sharing that data that are opening up a bit. So it's an area I think we'll be going into in the next year or two to make that data available.
Right. At my facility, we'll have clients come in and the UEMR will say, oh, they're allergic to all these different things. And then they will ask for those things they're allergic to. Like, oh, if you're allergic to milk and eggs, then why are you making an omelet with milk and eggs right now? Well, I'm not allergic to milk and eggs. I've never been allergic. So,
Self-reporting.
and then we'll send emails. Yeah, exactly. Self-reporting. We'll send emails and nothing gets changed. And it still lists all those allergies. And the same goes with medications. I was never on that medication. Well, it says look in their record. So,
Do you find those glitches?
The medications are a hard one, right? Because we can tell you what a doctor has prescribed or a nurse or has prescribed, but we don't necessarily know if a patient's filled the prescription, right?
or remembers.
Right,
Yeah.
right. And so there are some services that fill this. They don't provide data. They provide data more to doctors' offices and not to HIEs. And so we've been exploring ways to fill that gap. That's an area where in the future, like claims data may be helpful because if you don't know the person's taken the prescription, but if you can tell that it was paid for, there's a better chance than just having handed them a prescription in your office. So challenges I think we still need to tackle. Thank you. To give a quick sense of the types of data that we do get, and it varies by organization, what they do send to us and how deep the data is. And we continue working with them to try and get new data. The majority of organizations will send us what's called an admission, discharge, or transfer message. So that will show that somebody showed up at a facility, left a facility, was moved to another facility. It will have demographic information, sometimes some diagnosis information. That can be really helpful for care teams or individual practices to know that their patient has actually shown up in an emergency room, so they can follow up, or a care coordinator might want to know different areas where a patient is having care. We will get continuity of care documents. So that's the big list of all the historic information on you. You may, when you leave a practice, sometimes get the care summary at the end. They offer to print out that 20-page document. It's a lot of the information that's in that would be in that. So we have historical data as well as most current data. We'll get lab and pathology results. We get radiology reports. For radiology, we get written reports. The reading of the x-ray, we won't get the images. We get clinical notes and transcriptions. We'll get some home health monitoring data, and we do get immunization records from a large population of organizations. So with that, I'm going to turn to talk about some of the services we offer. The majority of the services I'll talk about first are really used by, I'm going to say providers, it's individuals providing care or helping to coordinate care for patients. That can be all types of providers in an organization. One, the kind of biggest one that we have is the clinical portal, Vital Access, we call it. And we'll talk about provider portals a bit earlier. And that really provides a picture into the patient's health records. So someone can go in and search for their patient's information and look through. And I'll have some screenshots in just a bit so I can show you a bit what that looks like. There is a delivery of test results, imaging reports, and notes. And so that is a service that providers can subscribe to. So we get data from the hospitals across the state, and we can then deliver lab messages or test results into the EHRs of the prescribing providers. So rather than the lab having to fax results or call with results, it goes right into the patient's record in the provider's system. So that's a really helpful service. And what that does is not just helps the provider have good information on their patients, but it also this is another area where having a hub, reducing the burden on organizations that have to deliver and maintain connections to multiple organizations is really helpful. We have capability for organizations to actually query from within their EHR to get patient records. A couple of organizations are taking advantage of that. So rather than going into our patient portal, an individual could be within our that allow this, could be the EHR and just say, find out what Vital has about this patient and see it kind of within their workflow. We've also been working with the Department of Public Health to allow querying of the immunization registry through Vital. So again, from a provider's EHR, they can go and say, does this patient have, what immunizations does this patient have, and actually see the forecast out of what they are due. And what's really great about this service is it can happen not just at the point of care while a patient is in the room, but a lot of organizations that have started using this service do kind of a pre-fetch. So at the beginning of the day, they know which patients are coming in. They can be prepared for who's coming in and what their needs are kind of ahead of time. And I think this has been a really popular service. And again, another area where we're reducing burden for public health staff to make the data available. We're not making the providers leave their systems. Another tool or another service that we offer, this is with a third-party partner, is event notification. So that's using those ADT messages I mentioned. And really, organizations can sign up for this service and know where their patients might be showing up or moving. Again, care coordination organizations use this a lot. They know patients who might have specific concerns they want to kind of keep on top of. They can be alerted when they're showing up at different facilities so they can reach out and help coordinate care. Finally, and I'll talk about this a little bit more on the next slide, is we offer custom reporting. So we can do extracts of the data, and that's where I had mentioned earlier, it can be more historical and more complete pictures and records. And this is, again, is a really a good illustration of where having the hub, having the HIE at the center of the data is really important, and our ability to kind of match and standardize the records to deliver. So we do provide data to a lot of organizations, and not just using our tools, but sending them data, right? We talked a little bit about the notification and the lab result delivery. We also provide a lot of data to the Department of Health, immunizations, reportable diseases. We provide a lot of data for them during the pandemic. We deliver data to by state primary care, the Vermont Blueprint for Health, and the Chronic Care Initiative. We've also in the past worked with the Accountable Care Organization. We are now working with Medicaid to provide data to help inform operations and patient care. So then I'm going to take a minute or two. If everyone's ready to talk about how the data is shared. So touch a little bit on the making choices, right? We at Vital take the kind of having access to the patient data and the security of the patient data very seriously. That having the community have the trust that we will, make sure the data is secure, but also make it available when it is appropriate. So there is access by providers is really important to our work. Data sharing is governed by agreements we have with healthcare organizations. It's guided by state and federal law, including HIPAA, includes vital policies and Appendix A of the HIE strategic plan that gets approved every year. So our data sharing in Vermont is a little more restrictive than HIPAA, but we do use HIPAA as a kind of benchmark and guideline. We maintain a very robust data security and privacy program at Vital. We have individuals that specialize in doing this. We follow national standards for what the security of our data looks like. We do regular tests and audits on the security of the data. And so that talks about kind of security or keeping it safe. We also have a privacy program, which is really focused on making sure we are sharing it appropriately, and then it is clear how we are sharing it and who that has access to the data, right? Because we don't want to keep this data, we collect this data to make healthcare better. We want to make sure it is available, right? Not make it hard to get for the people who should have it. We do take patient education very seriously, and this is something we do in Vermont that not many other state HIEs do, but is really, we have a very robust program with patient, of public outreach about how we collect data, what data is maintained, and how, what patients should know and understand about that, and that they have options about how their data is shared. And we do that through education campaigns each year. So we maintain a website that people have access to. We do throughout the year social media campaigns on the platforms. We also use radio and TV and Front Porch Forum during the year to get the message out to patients. And that is kind of something we are constantly paying attention to, and that helps. That is what shows up when we talk about 98.9% of Vermonters' data is being shared. People, Vermonters understand they have options. I think trust the system, want their providers to have their data. So I mentioned I would just do a quick showing of what the provider portal looks like. I won't spend a lot of time here unless you want to, but I do think it's helpful sometimes just to have a visual of what the data is. This is sample patient data. This is nobody's data, so it might not make sense, but I think you'll understand why it is that way. So if a provider does a search for a patient, this is kind of the first page that they would come to on that patient's record. And you can see it just kind of has a summary, right? And there are boxes that will show where the immunizations, what documents are available, what their test result history is. Then it allows them to drill down into more specifics. They can open any of the documents, or they can have a more specific view. So this is a view of if they took that same patient and wanted to see just their results. So they could see kind of a history of what tests have been done. They can see the results of the test, and they can kind of get a sense of what might be necessary or what's not necessary to do because it's already been there and we know the results for that patient. Stop for just a second. Is that great? I promise we're getting to the end. I want to highlight some of the work that we've been doing with public health. I think this is a really important focus of our work. And we'll mention, not many states are doing this. The partnership between the public health department and the HIE is not as strong in other states. And I think it's a real testament to the work that we're doing. And again, it's really helping us focus on getting the data once and making it available for all of the needs that exist, and not having different organizations have to be focused on getting the data and maintaining the connections, but really focusing on what they're good at. So this work started during COVID. We've all heard this story for 5 years. I won't go into the details of what we did through COVID, but it's really grown into doing a lot more work. And please help me here with some of this. Right? We deliver data into the immunization registry. We deliver a majority of the immunization data from providers to the immunization registry. We've expanded lab reporting for reportable diseases. So there's a long list of diseases that if a patient tests positive on, need to be reported within, I think, 24 hours to the Department of Health. We're working to get them that information again, so providers don't have to remember to do that reporting. And so they're getting really complete pictures of what's happening. And that's what we have currently happening. They use a provider portal in a lot of situations within public health to get them information, which provides more information than they might have had in the past, but also saves them from having to call providers and having providers send information to them. It's across different areas. One I think we're really excited about, this is at the end, is the WIC program. They're using the provider portal now to get data, but we're actually working to deliver data into the WIC system, the Women, Infants, and Children's program. That's a nutrition program that helps Vermonters. And what's really exciting about that program is not only does it like save the public health team from having to hunt down the data, but it also is going to save the individuals who benefit from that program from having to come in and bring data and have meetings, because the data will be available kind of automatically into systems. So I think it's a really exciting program. And what's really we love about that is actually we're building off of Idaho, I get it wrong. Iowa, thank you. We're building off of something that was done by an HIE in the public health department in another state, and kind of copying their model and learning from them, which has been great. Just to give you a sense of some of the work we have going on now and where we're hoping to go to keep improving. We are working now to collect social drivers of health or social determinants of health. There are different ways to term this data. But most organizations are required, and I'm not going to use acronyms here, I'm going to do my best to get it right. But the Centers for Medicare and Medicaid have a accountable health communities program where there's some required data that needs to be collected. It's a specific survey, which is referred to as the HRSN, or the Health Related Social Needs. I did it all right. Great. Thank you. That most providers are required to collect, and it's a standard set of questions. And we're going to be working with healthcare organizations to collect this across from providers and make it available to the organization, so patients don't necessarily have to answer the same question every time, but also so providers can understand where there might be needs that could potentially be met. Great. And then some other work we're really focused on, we want to make sure that we are getting data to providers in their workflows, right? We don't want them to have to go to other systems to necessarily get the data. And so we're looking at new tools and capabilities to get the data, make it so that for organizations that want that can integrate the data into their workflows. Lab results are a good example of that, but we want to do a lot more of that. We also want to make it easier to use some of our tools. So we're working to build some capabilities to do single sign-on. So if they log into their EHR at their facility, they can then open our provider portal without having different systems to find links to and log into. And I think we will continue to try to integrate new types of data. The social determinants of health are a good example of that. The Part 2 data over time, I think, is another good example of where we'd like to go. And then working with Agency for Human Services to really help with the kind of development and build out of the unified health data space. The areas that we want to go. So.
Thank you. A lot of information in a short period of time, and we're just beginning to get our arms around all of it. So we appreciate what you brought to us and what the direction you're going. So questions committee before we let these two take a rest. Okay, we're good. Thank you. Really helpful. We will come back to it. I think when Brendan Krause comes up, we'll bring up some of the next. You have the next steps here. It'd be important to stay connected on all of that. Okay.
Maybe off when UVM records were hacked.
Yes.
A number of years ago, Vital was one of the few places that was secure.
Yes.
Records could be found.
Yes, that was helpful. And actually one of our former Ledge council staff members was working at UVM to correct that problem. Yeah, he did a good job. Remember Brendan?
Yeah.
Yeah, he did a good job. All right, thank you. So we're gonna move to Brendan Krause from Director of Healthcare Reform at AHS. We don't take breaks in here. Anyone who needs a little break can take a break. We'll probably take a break after we hear from Brendan and Stephen.
Please.
Could open the door. Oxygen.
I know oxygen would be. Yeah, just for a second. Thank you.
Oh, yeah, but we could turn that, it's the air filter.
Oh,
It's on.
on that.
Thank you.
Okay, good. Yeah, we need it on in here.
Yeah.
I don't think,
It
I think
is.
that Stephen is the one on the agenda.
Stephen's the one on the agenda.
I'm
Okay,
next.
I've got both of you,
Oh, I'm
but,
sorry, I'm next Thursday. Sorry.
all right, we got you
Oh.
next Thursday. We got you. Okay, but Stephen is here. That's good. Good morning.
Good morning.
Is it okay to call you Stephen?
Yes, I go by either. Most people gravitate towards Stephen.
All right.
And for the record, Stephen Andrews, Director of Health Systems, Data and Analytics at the Green Mountain Care Board.
So we have your slides. Are you putting your slides, Kirsten putting your slides up? Or are you putting your slides up for us?
I'll be putting them up.
All right.
Are they displaying properly?
Yep, now they are. Terrific.
Okay, thank you. I want to apologize in advance for how I sound. I have COVID and I appreciate the opportunity to be on Zoom so I don't risk infecting all of you.
Well, sorry you have COVID. It's still here and we're still concerned about it. So thank you for being remote. Appreciate
Okay, you're welcome. As I mentioned, I work for the Green Mountain Care Board and lead the data analytics team. I'm fortunate to work with a great group of people in supporting the Green Mountain Care Board with data analysis to try help them make empirical-based decisions as they try to achieve their mission. My understanding was that I should talk about the two main databases that we steward. One of them I'll talk about in more depth because I think it's more relevant here. But before I go into talking about the databases in more depth, I do want to situate them next to what Will and Beth were talking about. They were talking about an EHR, which is really the patient's journey through the healthcare system from the point of view of the patient. And what we're going to be looking at are the journey for the patient from the view of the payer and the journey through the healthcare system from the view of the hospital systems. So the first database we refer to as the Vermont Healthcare Uniform Reporting and Evaluation System. We'll call it VCURES because that's a lot easier to say. The other one is the Vermont Uniform Hospital Discharge Data System, or VUDS. The other thing that the data team helps support at the Green Mountain Care Board is the Data Governance Council, one of the first in the state. We really try and take care of the data that we steward, make sure that it's secure, that we're respecting people's privacy, and it's the charge of the council to track that, to make sure the policies are up to date and are adequately protecting people. And feel free to ask questions throughout. Go ahead. I heard somebody say something.
I said thank you. It's okay.
Okay.
Yeah.
Just to ground what we're doing in terms of the data duties of the Green Mountain Care Boards, we have 6 duties coming out of 18 VSA section 9410. The first is that we need to figure out what is the capacity and the distribution of existing resources for healthcare throughout the state. And then sort of the corollary to that is we have to figure out what are the needs and how can we use those to inform healthcare policy. We also are required to evaluate the effectiveness of any intervention programs that are aimed at improving the healthcare experience for patients. And the corollary to that is to compare costs between different treatment settings and approaches. Taking all of that information together, we're required to provide that information to consumers and purchasers of health data so they're as informed as they can be and want to be when they're making healthcare decisions. It's a complex field, really difficult to navigate. We want to try to give them the best leg up they can have. And then the last charge is to improve the quality and affordability of public healthcare and healthcare coverage. We are required by statute to make these data available as a resource so that we can continuously review healthcare utilization, expenditures, and performance in Vermont. This is an ongoing process for us. So VCURES, the this is an all-payer claims database. So we're looking at the information provided by insurers and what they done to pay for the medical care that patients are receiving. This covers medical and pharmacy claims and eligibility to make claims, as well as some background information on the patient, where they live, who they are, kind of information. Pardon me. We do have 100% coverage of Medicare and Medicaid enrollees. After the Gobet decision, we only have about 60% of commercially insured enrollees. The Gobet decision allowed commercial entities under certain conditions to opt out of reporting to the state. This data is a rich database, longitudinal. We have a history of data going back, as you'll see, and it's very comprehensive in terms of the billing component. It includes information for Vermonters who are seen out of state, because based on 4 insurers who are based in state or covering enrollees in state, who did they pay for? So we don't have information about people who live out of state and receive care in Vermont. But it is restricted to the information that's needed to adjudicate claims. So as I was saying, to contrast this with what Will and Beth were talking about, they had the information about what happened at the point of care in the exam room. What did the primary care person or specialist say to the patient, and how were they managing their health care? This is that side that nobody likes to talk about. How did they pay for that health care? It was established in 2009. Vermont was one of the very first states to have an APCD. They were cutting edge. As of yesterday, 25 states now have an APCD, an all-payer claims database. BCARES is an important state resource. I'm not going to go into detail on all of these, but just sharing some of the state agencies and others that we share these data with so that they can do the work they need to do. VDH, DEVA with the blueprint that was mentioned by Beth and Will, Dale, JFO, DFR, and the UVM College of Medicine. So it's a widely used database, and it is a good resource for a lot of the work that's being done by the state. So just cover some of the basics again. It covers commercial, Medicare, and Medicaid enrollees who've received care. It covers the claims data starting from 2007 for fully insured and some self-insured claims. You did see me say 2009 before. That's when we started collecting the data, but some of the claims had actually started earlier than that, so it goes further back. The data are for Vermont residents only, and we get the data depending on the size of the organization. We get monthly, quarterly, and annual reports from insurers, from third-party administrators, and pharmacy benefit managers. The data are managed by OnPoint Health Data. It's a service that we work with the vendor to take care of the data. They've been with us since the beginning in 2009. They've been in business for over 40 years. You can see, I have a little bit about what they do. The key thing is that they provide us a secure portal where we access the data. Rather than sharing data and sending it to a data analyst, we bring the data analyst to the data. So more modern practice in the security world for making sure the data don't get exposed to leakage. They provide data integration services. They help us with data enrichment, coming up with additional views into the data, as well as end user support. I do want to mention the other database, even though we've asked to talk more about BCARES, I think the hospital discharge data, VUDs, is an underutilized resource that we offer. And I'd like to see more people taking advantage of the data. This data covers all patients who are seen at Vermont hospitals, even if they're non-resident. So it's really the activity, like I was saying before, the journey of the patient from the viewpoint of the hospitals where they're receiving care. It includes inpatient discharge data, outpatient procedures and services, and emergency department services. We can share these data with state agencies, providers, payers, and researchers. And I should note that right now, this started before I came on board. I've only been with the board for 6 months, so a lot of this is still new to me. But there was an agreement to move the management of the VUDS data from VDH to the Green Mountain Care Board, and that's underway and should be done by the late spring.
So let me stop you and ask, do you mind if I ask a couple of questions right here?
That's fine. This is actually the last slide, so this is an
right.
opportunity.
Oh, okay. I didn't see that. It was the last slide. Got it. All right, perfect. Good timing. So as you're moving the data from VDH to Green Mountain Care Board, how was that decision made?
From what I've seen of the documentation, it looked like there was a discussion between people at VDH and Kate O'Neill, who is my predecessor, about who should be actually doing the work to keep the database running. They'd been doing that work for us, and we were paying them to do that. But there
was a contractual relationship between VDH and Green Mountain Care Board for that.
Yes, that's my understanding.
Okay, that I wanted to ensure that we weren't going through changing statute on the fly. So I do have some other questions. The VCures obviously includes claims and clinical data. And then you've also talked about how you're sharing data. How does that sharing take place? How accessible is that whole database for anyone who would like to access it, including a hospital or a clinician or Vital?
It differs between state agencies and people outside of the state. All patient data is difficult to get access to by design. That's the nature of HIPAA and other security regulations to make it difficult to get access to. But we try and make it fairly straightforward. We have an intake form where they make a request for the data and that goes to the Data Governance Council, who reviews the request, make sure that it makes sense, that it meets the needs of Vermonters, and that it's not putting the data at risk. If they agree that it's okay, then we go ahead and share the data with the state agencies. And those can be for longer periods of time. If it's a researcher, go ahead.
Yeah, so if it's a researcher, that's one thing. How long does it take for someone, a clinician, to access that database to understand patient claims? What is the time frame between application for the data and then the actual access to the data?
I'm not sure we've actually had clinicians ask for those data, but it would take several months to go through the Data Governance Council. And Lindsay Kills, my deputy director, she's been with the board for much longer, and she might be able to address the question.
Good. Thank you. Welcome.
Hi. Thank you. For the record, my name is Lindsay Kill, and I'm the Deputy Director of Data and Analytics at the Green Mountain Care Board under Steve Andrews. Good morning, everyone.
Good morning.
Hi. So I wanted to start, and I put this in the chat, but I'll say it again here for the record to clarify that currently today, right now, VCures does not include clinical records. And so to answer more specifically your question about how long does it take a provider to access VCures for any of their work, they would have to go through the same process as anyone requesting the data. So that could take several months, and there would be there's typically a fee associated with getting it's called a limited use data set. There isn't, unlike Vital, there isn't a mechanism or like a portal for providers to go into and look up their patient's information. In fact, and this is a good point that I want to call out, all patient information, PHI that would go into the reconciliation of VCures and the generation of VCures is totally unavailable to the researchers. So the people on our end actually using the data.
So in terms of the hospital discharge data that you have, that's also not accessible to a clinician?
No, that data is accessible. However, it's accessible through the public use file request process. So again, the same way that it would be accessible to any member of the community or any stakeholder. However, also in the VUDS data set, any PHI is also scrubbed from that data. So it's what we call completely de-identified data. And VUDS actually goes a step further and has de-identified provider data. So while we can see the hospital where the discharge is from, there's no individual provider information on there, which would make it impossible for an individual provider to say, let me see my patients and look it up and leverage VUDS for that purpose.
Okay, so if a provider were looking for the discharge data, they'd have to go through the hospital portal or be connected in some way that way. Yep. Okay, thank you. That's helpful. And Steven, you wanted to make a comment, I think.
I was just going to add, I think it would also be a lot easier because they're already in the portal in their hospital, so they have access to those kinds of data. If they're in the hospital network, if they're outside of it, then they wouldn't have access to that. That really is where my question is coming. If you're outside of that, how do you know your patient's been discharged from the hospital? VUDS would not be the way to go because of the delay. Hopefully your patient, unless it's a very serious case, is not going to be there for many months. If they are, you're probably much more involved with them and would be aware what's going on. So maybe the VHI, I can't speak to that, whether the information would be in there in a reasonable fashion.
Do we have an answer to that? Where are you? There you are, Will. Okay.
Hi.
For the record.
Thank you,
Yeah.
Madam Chair. For the record, Will Dempsey, Health Data Officer, Agency of Human Services. So in the VHI, we have ADTs, admissions, discharge, and transfers, which Beth kindly touched upon.
Okay.
In her presentation, which you'll notice includes discharge, which this has discharges. It is slightly different. I believe the VUD system dates from the 80s.
It's a different data set, but it's still discharge information.
Correct.
Okay.
Yeah, that's my understanding. Is how I should catch that.
All right. So trying to get this all together. We're trying to understand how this all happens, on the ground floor for the patient or the clinician, so that information is there at the time needed. Okay. So then my other question is, I have a lot, but another question. Let me go back and find my other question. Sorry.
While you're searching, if I may add, I think the databases that the Green Mountain Care Board offers are intended and much more useful for after the fact analyses, sort of looking at, okay, how did the system work? Rather than patient focused, what happened to that patient at this moment in time now, which is served much better by what the database that Will and Beth were talking about.
So one of the things that you said very early on is that you're collecting data to use for policy recommendations as well as regulation. So as Green Mountain Care Board is the regulator, there's no question about that. And then in terms of policy recommendations, is that an ancillary to the regulatory process, and how is that used? The understanding, of course, that policy comes from the legislature, comes from advisory committees, comes from the AHS. We have a director of healthcare reform. I'm trying to sort out the distinction between the policy recommendation and the regulatory process.
Very clearly, what we do for the Green Mountain Care Board is for the regulatory process. I think that the data are made available to AHS and others where they can use it to inform suggestions they're making to the legislature about policy. It fits in more on that side. I don't think we make policy recommendations per se, but the data are available to use for that purpose. I hope that distinction makes sense.
Okay, yeah, no, that does make sense. Thank you. And then the question related to that, is, again, it's an application process. Then the board, previews what that request is, and then what happens next? Is data packaged for the request, or is access given to search the data? And then how much time does all of that take if someone's asking for it today?
I'll ask Lindsay Gill to answer that,
Okay.
question, please.
Yeah, that's good.
Hi, I'll do my best. So we don't generally get many requests from individuals in the community to access the data.
Actually, my question is with regard to any request, not simply
Any
that.
request. Okay.
Yeah.
Great. So they submit a request. So there's two ways to do that. If you are a non-state user or if you are a state user, it's different. You submit the request, and that request is reviewed by the GMCB data operations side and passed along to the GMCB's Data Governance Council. They meet every other month, and then they review those requests and they vote collectively whether or not that request meets all of the guidelines that we outline in our data release policies. There's a different word for those, but I'm just going to use that to describe them at a high level for now. Once that's approved, we send that to our data vendor, OnPoint. And with that approval is the list of all of the tables and fields that they need. OnPoint prepares a limited use data set. It's called an extract. That extract is made live in the secure Enclave environment. And then we and OnPoint, we, the GMCB data operations side, and OnPoint together work to give the requester access to that secure Enclave so they can log in, and the only thing they can see is the extract that they were approved for. And then they can work in the Enclave directly with the data. And we have additional data policies and protections on what data can come out of the Enclave, and we review and approve that. And then we generally also provide a certain level of support for people when they access the data in the Enclave, because 10 times out of 10, when somebody gets access to vCures, they're very overwhelmed with how to use it. And so we provide, us and OnPoint provide the training for them to be able to navigate all of that data and get out what they actually need.
Okay, so how much time does that take?
Probably anywhere from 4 to 6 months.
Okay, and thank you. If I'm in the middle of a research, this sounds like a research-based request, the timing of it. And I'm making an application for a grant, 4 to 6 months, might torpedo the grant. I mean, have you? Yeah, no, okay, thank you. And then if it's a clinical assessment piece for my patients that I have in the hospital, do you have a fast track for any of our hospitals or other folks in the state, who people you've gotten to know in the process where you allow for more timely access?
Yeah, so that's a really good question. So I just want to make a distinction. So Medicare data is not available to the way that we get Medicare data is through a data use agreement with the federal government. And in the terms and limitations of that agreement, it states that the only thing that Medicare data can be released for is research purposes. So we don't, and so that it's all there on our website, and I don't want to misspeak. I'll probably want to go back and review it and submit in writing like exactly the process there, but there is today, to my knowledge, no clinical use case for that. We don't release data for that clinical purpose, especially not the Medicare data, because it would violate our DUA and we would lose the Medicare data and the APCD. For Medicaid and commercial data, it would, I believe it would still have to be, it can be a clinician doing it, but it still needs to satisfy all of these other terms and conditions that we have as part of our data release policy. And it would be up to the Data Governance Council whether or not all of that met. As directly to your question on do we have like a fast track, we have tried in the past to fast track it when somebody says like, hey, this is what we need and when we need it by. But there's not a specific, like on our website, a way to get this data in 2 weeks or anything like that.
And
If I
then,
may-
yeah, go ahead, Stephen.
If I may add, that's part of why we have longstanding agreements with the state agencies who use these data. So they don't have to keep coming back to us and going through that process. They can access the data for a set of years to do what they need to do. I also want to mention again that these data are collected on usually a quarterly basis. So the data are not meant to be used for analysis of what's happening today. You'll often find that it's a quarter or two back because the groups that we're working with don't always deliver their data on time. It is much more of a after the fact analysis of what was happening.
Okay, and does the state pay for access to the data or others pay for that information? Data acquisition?
I don't believe the state does, but there is a charge for groups outside. I think we've always felt that we're here to support the work of the state and providing these data to outsiders, to the researcher community is a nice to have, but it's not the main purpose of these databases.
Okay, and then, so at some point, I think we'll come back to this, but at some point it would be helpful to hear about some of the requests that you've had, some examples of requests that you've had, and then who are the outsiders that we're talking about?
We can certainly prepare that.
Yes, that would be extremely helpful. That would be helpful. We're trying to get our arms around the difference between the database that you have and that you're using for regulatory purposes, but then also we're hearing that it's being used for other purposes, for which when we established Vital, we thought Vital was the place for some of these purposes. So it seems that there's two things going on and they're both the same, or we could integrate those uses in some way. So that's where we are. And then we'll come back to this. We will have a discussion about either a committee bill or a bill that we put on the table to look at EMR, EHR going forward. It's never clear. It's in our committee, we have a saying, it's more complicated than that. So we're learning that it's more complicated than that. Well, thank you for your time on this. And we're going to